Hello, and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to Jake Beech, a policy fellow from the think tank The Health Foundation, about why we need to change the way we think about access in general practice. Jake is involved with a research project that's a partnership between the Health Foundation and this institute, looking at what access in general practice means, and which is developing a candidacy framework that provides a series of interventions and ideas for how we can improve access. In this conversation, Jake explains why access is much more complex and nuanced than just thinking about supply and demand, and how practices could use the candidacy framework to help better understand their patients and develop solutions that suit their needs. We also talk about the limitations with national data on general practice appointments, which are often used by policymakers to make decisions, and why patient satisfaction with access is so low, despite the fact that practices are delivering more appointments than ever before. I'm joined now by Jake Beech, who is a policy fellow at the Health Foundation. Jake mainly works on primary care, providing policy analysis, research and commentary. Before he joined the Health Foundation, he was a researcher at the King's Fund, where he had a focus on general practice. Jake's been on the podcast before, but he's here today to talk about a Health Foundation report that he co-authored called Rethinking Access to General Practice. Thanks for coming back on the podcast, Jake, to talk about this latest piece of work.
It's lovely to be back, Emma. Pleasure to be here.
Talking about access to general practice, we know this is a real political focus. It's definitely been top of the list of priorities for NHS England when it comes to primary care over the past year or so. What were you aiming to look at for this paper?
Well, really what we're trying to do is set out a programme of work that really looks at access in a sort of a deep dive way. So this is the starting gun for a series of pieces of work that really kind of gets under the hood, hopefully, of what access kind of means in general practice. With this paper, we're trying to do three things. We are setting out what the picture is currently with access. So what does the data tell us? What does the evidence say around access? Sort of telling sort of truth from fact, myth busting perhaps. The second thing we're trying to do is introduce this idea of candidacy as a way of understanding access in a more nuanced fashion that kind of gets away from some of the more usual conversations about just supply and just speed of access to really kind of introduce some of these other ideas. And then finally, what we did is go through over sort of 400 different sort of interventions, ideas for improving access, and create a bit of an options list, a catalogue of many of the things, almost all the things that have been tried before in general practice to improve access, point sort of readers in the right direction where they might find out more, and just show the range of things that you might do in this space. So that's what we're hoping to do with this paper.
One of the things, we've seen a massive rise in the number of appointments delivered in general practice over the past few years, but patient satisfaction with access is still really low, despite the fact that more people are getting appointments. Did you get any sense about why that is?
It's a really good question, isn't it? And it's a really tricky one. So you're absolutely right. I mean, we are seeing appointments in general practice going up from what the data is telling us. The Health Foundation keeps a tracker on our website that sort of shows the appointments over time. And you can see now we're sort of at or near record levels of appointments. I think last October sort of holds the record, and I think it was about 38 million appointments in that month, which is huge, especially when you consider kind of the population of England. But all of that is against the backdrop, of course, of kind of a declining number of your full-time equivalent, fully qualified, permanent GPs. So if you take out the locums, if you take out the GPs in training and just kind of look at GP partners, salaried, retainers, just look at the numbers there, as you can actually see they've gone down since 2015. And of course, we've also seen in that same period, mainly from 2019 with the Rs, a sort of a massive uptick in the number of what they call them additional roles, direct patient care staff. We're looking at over sort of about 35,000 more of them coming in. So there's something going on there. I mean, we have the skill mix change. We've got huge numbers of appointments. Another sort of element of this is, of course, kind of the discussion around remote versus face-to-face appointments. So you saw, obviously, pre-pandemic, number of face-to-face appointments as a percentage of all appointments, quite high. I think it was something like over 70%. It dropped during the pandemic. And since then, it's kind of gone back up over time. But what you're not seeing, if that is solely the reason, as some have suggested, for the kind of the issues, the dissatisfaction with access, you'd expect the kind of satisfaction to go back up, but you don't necessarily see that. So again, there's something more at play than just routes to access. You've also got kind of the question of timeliness as well, which is another part of access. And you see what the data tells us is that about 40% of appointments are on the same day as booking. And if you look at within a week, it's about 70%. And in sort of 2 weeks of booking, it's about 80%. So again, this element of timeliness, it's sort of quite tricky to unpick because on the face of it, some of those numbers are good. But when you look at kind of the experience of booking an appointment, you look at the polling, people are reporting decreasing satisfaction with making an appointment, with the experience of contacting their practice, and fewer patients are satisfied with the appointments they're offered, the timeliness of appointments, and their ability to see their preferred GP. So really, when we're thinking about access, there's just so much to unpack. There's the skill mix element, the number of GPs, supply and speed are important, but also the mode of access. It's so nuanced. And across all of that, you've got the inequalities question as well.
One of the other things you looked at in the paper was kind of this historic attempts to address access. We talked there about the fact that this has become a real political priority in recent years, mainly since the pandemic, but it's always been an issue, hasn't it? That's something political parties have talked about for many years in the past. Is there anything we can learn now from other ways that people have tried to address the access problem in the past?
It's a good question. And I think that kind of evidence-based policy making, learning from the past, kind of keeping that kind of evidence-based accessible to people is really important. But I think there's something interesting about just sort of the sheer range of things that have been applied, because a lot of these access initiatives, a lot of them are kind of grassroots, as you might imagine. A lot of them are kind of like led by GPs on the ground. And that doesn't necessarily kind of show up in the kind of a national policy picture. So I think to really understand access and what works, you've got to go both look kind of the national policy and politics, but you've also kind of go the situation on the ground. So that's what we've tried to do with this options list, pulling together the evidence across the board on what's been kind of tried around access. Your listeners can find that in that long read on the Health Foundation website. There's an annex, and it basically sets out across 6 domains and a series of subdomains, all the different things you might sort of consider if you were thinking about improving access. So, for example, one of them is appointment innovations, so how you might use triage methods to optimize it, use of telehealth, that falls under there. You've also got giving patients direct access to services, things that have been tried in that space before, from self-referral to physiotherapy through to community pharmacy. You've got increasing the range of professionals. We're seeing a lot of that at the moment, of course, with the Rs scheme, but previous attempts to do similar things with perhaps other roles in there as well. You've got offering contacts beyond core general practice hours and core settings. So different ways of kind of approaching general practice, different models in there, supporting patient empowerment, how patients see themselves as candidates for care and how they think about, well, I need a general practice appointment today, or I need a different type of service. So how you kind of make patients informed, make good use of those services. And then finally, kind of the other category we look at is supporting the internal and wider structures of general practice. So things like horizontal integration, vertical integration, different models of provider, the wider support. So all of these things have been tried. They're all out there. And what we've tried to do is kind of collect those, both national policy and grassroots, to paint a picture of all the different things you might try. But if we turn back to kind of the political and policy element of it as well. So what we did as part of this was a bit of a review on all the kind of the policy documents around general practice and access since the year 2000. So looking across New Labour, coalition governments, Conservative governments, and then the Conservative governments more recently as well. And what are the kind of the key themes there and how they perhaps think about access? And you definitely kind of see some differences, but there are also some consistencies there. So, for example, greater use of community pharmacy. That's an idea that you see right the way through from the year 2000 to present. It's fairly consistent. Interest in competition and different types of provider and contract. Many people think that's perhaps more 2010 onwards, but you definitely see that the 2000 New Labour years as well. The importance of choice, satisfaction measures. We're seeing those recently as well, trying to track on an ongoing basis people's feelings of access and kind of being really responsive. But again, that's not necessarily a new idea, as well as things like direct access, more 111, use of websites. Again, all of these things are fairly consistent, but there are differences. So in the New Labour years, you did see more emphasis on that big flagship 24, 48-hour target. So there was much more of an emphasis on the target, of course. Darcy centres were big. Interestingly, a conversation we don't necessarily have recently, but kind of an emphasis on commuters as well that kind of came out. So people being able to register in multiple places, a GP practice closer to their work. Issues with continuity and other things mean that perhaps it's not something that was taken forward, but it was definitely kind of an idea that was live at the time. And of course, with the 2004 contract, there was a range of things to kind of tweak that during the New Labour years or kind of address some of the challenges that arose from that. So things like out-of-hours access and sort of making sure that money follows the patient, of course, with an eye, again, on competition. With the coalition, you see a firm focus perhaps on choice and measures to improve choice, so data to support competition. You saw the emergence of the vanguards, and you also saw kind of their flagship policy, dare I say, at least in those early years, the PM's Challenge Fund, with this idea of letting 1,000 flowers bloom.
Some of these things, I think they're obviously in my brain, and I remember writing about all of these things, but they're kind of things forgotten about, really, because obviously things move on.
It shows the importance of kind of doing this kind of evidence review, of going back and saying, well, what has been tried? What was the evidence? And if they weren't evaluated, why not? And what might we learn that we didn't? Or what can we learn now from looking back on them? So I think that's really important. So if you move on from kind of the coalition, you start to see in kind of the Cameron era, sort of that pivot from competition to collaboration, focus on 7-day services, more integration. So it moves from competition to collaboration. And then more recently with kind of May, Johnson, Sunak, their era, you're seeing that focus on PCNs and sort of scale as a way of supporting general practice and supporting access. The growth of MDT working, massive growth, as we've said before, more use of community pharmacy again. And that more recent focus, the one that's kind of live in a lot of people's minds right now and in the policy discussion of modern general practice access, which is, the kind of the key phrase in the access recovery plan from last year, and is all about kind of moving away from the scramble at 8 a.m. and focusing on the front door experience. That's how they're conceptualizing it. None of these are hard and fast, of course, but they kind of give you an idea of the general themes that sort of emerge over time. Suffice to say, concerns about access aren't new. The flavours are different, but I think there is something perhaps about the challenge at the moment and the workforce challenges we're facing that perhaps does make it slightly different.
The paper really points out that challenges with access to general practice is about multiple problems rather than one simple thing. But it points out that policymakers often tend to think about it in terms of a very straightforward thing about supply and demand. And a lot of the things we've seen recently are very much around that. But it's much more complex than that, as you point out. So what other things do we need to be considering when we think about access?
Well, this is something we're really trying to get at through the lens of the candidacy framework. And we're hoping this will be a valuable tool for your listeners, for policymakers, for GP practices across the country to kind of get under the hood of what is driving concerns about access and really kind of tailor their offer to make sure it works for, well, both the practice and, importantly, the patients as well. So candidacy is a different way of thinking about access. It starts right at the beginning, how people perceive their symptoms, how people identify general practice as the way of meeting their needs. And of course, that's changing with things like social prescribing link workers. Maybe the offer of general practice and what it can help support with has changed. I think that's an important thing to bear in mind, especially again with the skill mix more generally, not just link workers. It's about having kind of the resources, cognitive, physical, transport links, socioeconomic power to find their way to general practice and sort of present themselves and say, I want to receive care here. It's about having the tools to meet their need. That could be interpreters, that could be, digital tools. It's about how you access those services. The important context that sits behind all of this, a complex and resource-constrained environment that general practice operates in. So making sure that all of the kind of the policy architecture is there to ensure practices are well placed and well funded and resourced to meet the needs of their patients. So candidacy is all about identification, navigation, permeability, appearance of services, adjudication, offers and resistance, and then the wider operating conditions of general practice. And if you have those in mind, you can really start to tease apart some of the challenges facing access locally as well as nationally.
Does the candidacy framework that you're talking about, does it also help look at things like unmet need? Because obviously when we're talking about access, we're not just talking about the people who actually do manage to get on the phone. There's obviously a certain group of patients that don't really interact with healthcare, and practices need to be considering them as well, don't they, as part of the way they look at how they address the access challenge in their local area.
I think it's a really good point to raise. One of the uses of candidacy, having this framework, and some of the work that we're going to do over the next sort of couple of months across the sort of 2024 will kind of shed light on that. I think this is very much a tool for kind of unpicking some of those local challenges. It kind of gives you a way of thinking of the different elements and perhaps the different barriers and challenges groups face on a local level to access to general practice. So it helps you kind of unpicking some of that. And I really think it can help sort of structure your thinking.
You were talking there about the data that the NHS uses and the national newspapers now use to assess how GP practices are doing on access. But there's lots of limitations with that data, isn't there? We write about that data quite a lot. And what are some of the problems with that? And how is that likely to affect the way people perceive access potentially?
I've done a few Twitter threads on this, actually, at Jake C. Shameless plug, Emma, you'll have to forgive me. There are some limitations. I mean, it's better to look at the national picture with that data than look at the local picture for a couple of different reasons. But if we kind of unpick some of the elements of that data, I mean, let's look at the timeliness data, right? So within that NHS digital GP appointments data set, you can have a look at the time between booking and the time the appointment was delivered. And as you might imagine, there's potentially interest in using that to kind of measure waiting times. But it's not necessarily waiting times that's measuring. And I think you have to bear that in mind when you're looking at that data. So there's a couple of, very good reasons why it might be more than 2 weeks that you're waiting, for example. So it could be patient preference. It could be an appointment with somebody and you're booking them in for a follow-up more than 2 weeks down the line. That's not to say all appointments beyond 2 weeks fall into that category, but we just don't have the data to be able to understand that particularly well. So I think any timeliness data of appointments that you're looking at in that context, you kind of need to take with a pinch of salt. Same goes, I think, for the individual practice level data as well. So, in theory, in this data, you can get down to the level of individual practices, look at the number of appointments delivered. And I think, again, there's some important caveats you have to bear in mind when you're looking at that. It'll tell you some things, but it will be limited. It won't tell you everything. And again, there's important nuance and context there that you have to take into account. So when you're looking at these appointments per practice, you've got to think, well, what other activities going on in general practice? There's other referrals, there's other types of activity that goes behind the scenes. It's not just appointments that are going on. These appointments will also have to reflect their patient profiles of the area. So again, you need to kind of consider kind of the case mix, the patient population in the area. Again, not context that you can get at easily in this data, but all important. And of course, you have elements of inequalities in there. So things like deprivation. Is the number of appointments being delivered in an area a function of the supply? Has to be, surely. We know from the evidence that the inverse care law very much persists in general practice. Practices in more deprived areas are underfunded and underdoctored relative to their needs compared to their more affluent counterparts. So when you're looking at kind of the supply of general practice in those areas, you have to think about the limitations within kind of national policy that perhaps set them up for that. So I think there's an awful lot of stuff you have to consider when looking at that data. And that data is also evolving, of course. Only recently, we've started to get quite a lot of information on appointments that were done at PCN level that we didn't have before. So I think almost 1 million more appointments are now going in each month from PCN recording systems that sit outside core general practice systems. So you suddenly have, another 1 million appointments, many of which, although we can't tell yet, are probably done by our staff. So again, it's an evolving data set and one that requires a lot of interpretation, a lot of context that we don't necessarily have. So you kind of have to take it with a pinch of salt.
You talked about the candidacy framework a bit. So if you're a practice and you're interested in listening to this and you're interested in what this candidacy framework, how would you be able to go about actually using some of the work you've done to kind of maybe look at access in your practice and how you might improve things?
Well, what we're hoping with this initial piece of work is that it's only the starting point.
Right, okay.
Using that candidacy framework as a guide to help guide your thinking. Think about things that are kind of beyond the things that immediately leap to mind, which at the moment are all about supply and speed. Adding in that nuance, the options list that we've produced gives you kind of a suite of ideas that you might sort of try and consider. And as I said before, some of them are very much kind of national policymakers' gift. Some of them are very much more local or could be local driven. But it really gets to the heart of what we're trying to do with this piece of work. So what we're aiming to do across kind of the next projects in this series that the Health Foundation is doing in collaboration with this institute is, one, look at how candidacy has been used in kind of the academic literature to think about general practice in the past. Two, we'll be developing a kind of candidacy specific to general practice, so drawing on the evidence, kind of refining it, because as your listeners will know, general practice is quite unlike most other health and care settings. You've got continuity, undifferentiated illness. You have to have something bespoke to be thinking about this. So that's what the candidacy framework plus the GP version that we're developing, producing a paper that will kind of look at candidacy through the lens of general practice. And that's coming out quite soon. So that will give you a kind of idea of some of the challenges, some of the how the issues that are currently topical relate to candidacy. And then finally, and perhaps the biggest bit, will be a piece of work we're doing where we're interviewing around 70 staff, patients, to really refine this candidacy GP framework, but in an iterative way. So we'll be refining that to make it a more useful tool, but also using that framework to kind of get at what staff, what patients are saying are kind of the key access issues at the moment, and really kind of delve into what candidacy means in general practice right now. And across that suite of tools, I'm really hoping there will be something of use to many of your listeners when they're thinking about access.
That sounds really great. I'm sure lots of people would be really keen to see that. But obviously you talked there about the fact that some of it's a national level gift, policymakers gift. So are you hoping that policymakers will also be making use of this to kind of shift the way they think about access and potentially change how they approach it as well?
Absolutely. I think the nuance is really important, as we've hit upon several times. The conversation can't just be about speed. It can't just be about supply of GPs. Both of those are really important, but they're not the whole story. So bringing that in, bringing in other elements of, I don't know if you call it access, but definitely people's experience of general practice and their experience of accessing general practice, things like continuity. You have to bring that into the conversation as well, and perhaps move beyond this antagonistic idea of access versus continuity and take that more holistic view that looks at both together, as well as the range of other activities that go on in general practice and how patients experience that. So I think that's really, really important as well. It's almost a cliche, but it's nonetheless true. One size does not fit all. It has to be tailored to local populations, especially given the inequalities we see in things like continuity and access measures between different groups, not just deprivation, but also, according to the GP patient survey, things like ethnicity as well. And across different groups, it has to be locally driven.
I was at a conference not so long ago and I saw someone talking about this, and for quite some time people have been so obsessed with this whole idea of face-to-face, like GPs aren't seeing people face-to-face. But one of the benefits of people embracing new technology is that it has actually helped some practices reach groups that were finding it very difficult to interact with their practice because it was all based around a very much face-to-face model before the pandemic. For example, people who have 0 hours contracts find it really difficult to take time off work. It's actually easier for them if they can email or do an online consultation. And that option just wasn't available 6-7 years ago to many of them. So it's not as straightforward as the Daily Mail or some of the other newspapers would like you to believe, really, is it?
Well, it's certainly not a straightforward question, access. We did an analysis using data from online triage systems that suggests most patients actually prefer a telephone appointment. But that's hard also to square with what we're seeing from kind of national polling and surveys, which say making it easier to get in-person appointments is one of the priorities for the NHS. So I think, it really speaks to this complexity, and different groups really do have different needs. And it's a time of real change as well. I mean, since 2019 onwards, we've seen primary care networks. We have 35,000 new direct patient care staff coming in. And with COVID slap bang in the middle of that, and the impact still being felt in many ways, have practices, have PCNs kind of had the headspace to implement and integrate a lot of these systems, not just digital triage, but things like ensuring skill mix is bedded in, ensuring these new team members are integrated, implemented effectively, patients know who they are, that they can be trusted. And a lot of that has to be done, obviously, at kind of the practice or team level. There's a lot of evidence about the importance of kind of the culture change, as well as the more kind of architectural changes, digital platforms, making sure people have the email sent to the right place, to the right member of staff, linking up information. All of that is important, but you've also got the culture element of it, and ensuring that patients have a good experience and feel that they can trust these members of staff, and ensuring that they're all seen as part of kind of the general practice team as well. And I think that's often missed, and it's really, really important as well. So time and space for GP practice to make what they have been doing so well over the last sort of 5 or 6 years work for the long run, have the time to really let it bed in.
I was going to ask you about that, actually, because obviously, like you said, we have got these 30,000 new staff that are working in general practice coming over the last sort of 5 years. But as I said at the start, patient satisfaction with access is still quite low. So these new staff obviously haven't sorted it. Do you think we just need more GPs?
I think, I keep saying it, but it's undeniably true. And that's, again, why we want to look at this through the lens of candidacy. It's so complicated. These challenges, they're so multifaceted. Part of it, which is about sort of bedding in these new roles, getting the MDT working, getting the culture change and the kind of the practice architecture right. Obviously, there is a real issue at the moment with kind of workforce. We have done Health Foundation projections through to 2030-31, and we found that kind of in a status quo scenario, sort of this was before the workforce plan came out, but of course it hinges on that kind of being implemented effectively over the next few years. Our status quo scenario would see 1 in 4 GP posts vacant by 2030-31, and in a kind of pessimistic scenario, it will be 1 in 2. So I think supply of GPs is obviously a really important part of the answer, and not just kind of training as well, but retention of GPs and looking at kind of holistically. So again, it's multifaceted, and as well as kind of the supply things, I keep coming back to this point, but as well as kind of the supply of new staff, of new GPs, it's about a nuanced understanding of what it means to kind of provide access to general practice on the ground at the moment. And I think candidacy can help cut through some of that as well and kind of pivot the conversation.
And what about patient education? What role does that have to play?
We've seen massive change over the last few years as well, especially again with COVID sort of in the middle of it. One of our key categories in the options list that we've produced of things that have been tried does focus on sort of patient education, patient support. It's not just about education. I think it's not quite the right term. It's about sort of reaching across and supporting patients, guiding them, helping them make use of the resources they've got. Again, it's a more nuanced understanding and supporting patients to see themselves as kind of a candidate for care. I mean, that's at the heart of candidacy. It's sort of taking a patient-centered view of access and saying, what does a patient need to understand that they need to access general practice? How do you make sure it's a good cultural fit? How do you make sure that even before a patient sort of comes to general practice, that they have the tools they need to navigate the system, access general practice, and then once in the system and in general practice, you know, advocate for themselves, find the right place, have good communication with the GP. It's not just about education. I think that limits the conversation. It's about so much more. And again, if you look at our options list, there's all kinds of interventions in that space that GP practice might sort of consider, spark off a few ideas, hopefully.
Well, that was great. Thank you so much, Jake, for coming on the podcast.
Thank you so much for having me, Emma. It's been an absolute pleasure.
Well, that's it for this week. Thanks for listening, and thanks so much to Jake for taking the time to talk to me. You can find a link to the work that Jake's doing with the Health Foundation and this institute in the show notes for this episode. I'll be back next week for our regular news review, so please do join me then. Don't forget you can keep up to date with all the latest news affecting general practice and access a host of other resources on our website at GPonline.com.